I am very excited about our speaker this afternoon, Robyn Tolley, a friend, a colleague who will share her expertise on the evaluation and treatment of extravasation injuries from chemotherapeutic agents. It's almost like a tongue twister.
It is.
Robyn is a nurse practitioner at the Cancer Center at UNC. She is oncology certified since 2018 and hopes to take her advanced oncology certification very soon. So her top 5 in her bio, to continue on, she attended graduate school full-time while working full-time in inpatient surgical oncology nursing. She has earned her associate's degree up through her master's degree in nursing programs at the University of North Carolina, Chapel Hill. And her associate's degree was from Baptist School of Health Professions in San Antonio, Texas. And a fun fact is it is one of the oldest hospital-based nursing schools in Texas and founded in 1903. And her professional interests in hematology oncology strongly lead toward symptom management. So thank you, Robyn, for being here and sharing your expertise. Outside of your professional bio, something you'd like to share with our audience, a hobby?
Yes, I have several hobbies. Thank you for having me, Tammy. I'm really excited to be here. Probably the most time is spent with my twin girls. They're 12. And because I'm crazy and take on a lot of things, I'm a Girl Scout leader and a volleyball coach and miscellany of other leader roles instead of just observer roles. And we love turning one entire room in our house into like an entire Lego town. We're Lego people.
That's super fun, talking one Lego fan to another. This is a sample of what your Poll Everywhere questions will look like. You will have an opportunity to practice in a moment. I just wanted to share what it will look like, pollev.com/UNCLCN. And our first practice question is: extravasation is the leakage of blood, lymph, or other fluid, such as an anti-cancer drug, from a blood vessel or tube into the tissue around it. True or false? Here are our disclosures. And yeah, thank you for participating. So how are they doing, Robyn?
They're doing perfect. They're doing perfect. That's exactly right.
So I will now hand it over to Robyn.
All right. Okay. So based on our question on the extravasation, from the Latin extra meaning outside, vas meaning vessel, it can be a process or a medical condition. So in the body as a medical condition, this can be your white blood cells moving through your vessels to an infection or injury. It can be cancer cells metastasizing to other sites, traveling through your lymph system. For the purpose of this lecture, we're going to talk about it as a medical condition, which occurs when fluid infusing in an intravenous catheter leaks out from around its site into the surrounding tissue. And you've probably heard the term extravasation and or infiltration. And the important thing to know is physically they're the same thing. Infiltration is leakage of the fluid. Extravasation is leakage of the fluid. Infiltration is of drugs or fluids that do not irritate the vein or the site where it extravasates. The extravasation leakage does cause damage to surrounding tissues. For cancer treatment, intravenous infusion is our principal modality. And although it's really hard to find data on how many infusions occur, it's thought to be greater than 1 million per day worldwide. There is no central reporting system for extravasations, so it's really difficult to kind of quantify that. to really get perspective on how often this is happening. But there are some sources that list it to be between 0.1 to 6.9% of infusions. On the lower end, the 0.1 to 3% is more likely to be your central lines. On the higher end, up to the 6.9%, your peripheral lines. Extravasation is an accidental complication, but it does come with serious consequences for some patients. Some complications that we're looking at include altered limb function if we have damage to tendons or muscles, superimposed infection that requires antibiotics. Sometimes the extravasations are so serious, you have to suspend their actual cancer treatment while they heal from the extravasation injury. They can have significant tissue damage requiring plastic surgery and possible skin grafting. Pain is a significant complication, and they can go on to require narcotic pain medication. And then the quality of life is really important to consider as well, be it from like physical, mobility dysfunction or psychological, because a graft could definitely cause them to look different than they do. There are a couple of different categories of risk factors that we're going to go over. Drug properties is number one. So what drug you're infusing plays an important role, right? Vesicant drugs are going to have properties that make them highly vasoconstrictive. So they're going to reduce blood flow to the area they extravasate. And also, they frequently have slow metabolism of the drug in that area. So then the drug remains in the tissue for a longer period of time, causing ongoing issue. The concentration of the drug, which includes the pH or the osmolarity. So really low and really high pH drugs are going to be more harmful. Same thing with hypo or hyperosmolar agents. Hyperosmolar is more damaging, but both ends of the spectrum can be harmful. The total volume of drug you're going to infuse. Larger bags of infusion of vesicant are going to be higher risk for extravasation, in addition to how long you infuse it for. So if you have a really large volume vesicant that infuses over a short period of time, you're more likely to cause damage to the tissue. Patient properties are one of the risk factors associated with extravasation. So this is going to be like patient anatomy, right? Small fragile veins, hard sclerosed veins. Do they have any pathophysiology in the arms or whatnot that makes it difficult to gain a good, stable IV access? Patient education, I think that sometimes people expect intravenous infusions to be uncomfortable and don't necessarily report out if they're having any issues while it's infusing, or even after it's done, if they notice any swelling or tenderness. Altered or impaired circulation, so people that have lymphedema, peripheral vascular disease, diabetes, neuropathy, can be difficult for them to sense if the fluid is no longer running into the vessel. People that have an impaired level of consciousness, if they're agitated or if they have communication difficulties, won't be able to call out and let somebody know quickly if something is wrong with their IV. Certainly, if it took multiple attempts to gain IV access, that's just more and more holes you've placed into someone's vein. And our obese patients who really fall into that category of sort of an anatomic type things, right? It's a little bit harder to get through the tissue and get into a good vein. And then we have the iatrogenic properties. These are healthcare associated. So you're talking about the technique for getting the IV in, the nurse that selects the appropriate or inappropriate size IV for the vein that they're attempting to cannulate. If they can only find something in the hand or in the antecubital, so they're not going in the forearm, that's going to be a poor location selection. Usually, more experienced staff that have more experience doing venipunctures and intravenous insertion do a little better. Initial and ongoing training for nurses so that they have comfort and can be pressed for time, right? Patient after patient after patient coming through. And so you're just putting in your IVs as fast as you can, and maybe you didn't pick the best site, the best size catheter, or maybe you didn't get a really great blood flow, but just a little blood flow. That can be a risk factor as well. So we've got our next poll everywhere question up here. And it's only vesicant drugs can cause serious tissue damage when extravasated. True or false? Yeah, see, you guys don't even need me. You already know this. That's right, it's false. So we're going to go over our classifications of drugs right now. And really, again, just talking about chemo, we have irritant, vesicant, and non-vesicant is a good title for that. So irritants cause localized pain, swelling, redness, but usually don't have any sort of skin breakdown. No blister, no sloughing, nothing along those lines. Vesicant drugs have a high risk of causing tissue necrosis. After really the formation of the blister, then you can proceed on to tissue necrosis. And then our non-vesicant, non-irritant, or neutral drugs are going to be ones that don't really cause any damage to the tissue, but the patient can still experience a little bit of discomfort at that site when it's extravasated. It's mostly going to be like swelling and tenderness, but it's going to resolve really quickly. This is one of many charts on the different types of chemotherapy drugs. And so you're going to find that these charts differ from each other in some ways. Anthracyclines are probably the biggest offender for extravasation. So that's always going to be the same. The vinca alkaloids as well. But taxanes can be listed in the irritant category, so it can be confusing for people. I definitely think you should check your policies and your resources to see which way they're going to label those drugs for you. But really, anthracyclines, vinca alkaloids, and the anti-tumor antibiotics, the mitomycin group down there, those are going to be the biggest vesicant medications. Then we have some irritant drugs and the non-vesicant drugs listed on the other end. Vesicant drugs are actually broken into two categories: DNA binding and non-DNA binding. So DNA binding are the ones that are going to cause the most damage because the drug itself binds to the DNA in that dead cell. So it can't be like metabolized out of there easily. So it stays at the location of the extravasation and continues to cause damage to the skin there. So the DNA binding vesicant drugs, if you have to remember anything, are the ones that can cause the most serious damage. And up to a third of all extravasations of DNA binding vesicants can produce ulceration and necrosis if left untreated. Your non-DNA binding vesicants, they inhibit DNA transcription, which cause cell death in the skin there, but they're easily metabolized, typically back into your circulation, and most of them are voided out. But the damage is generally mild to moderate and improves within 1 to 2 weeks. No ongoing issues with those drugs. So when you go into our first chart that had our vesicants listed, this goes a little bit further, and it takes those vesicants and puts them into DNA binding and non-DNA binding categories. So your anthracyclines and your anti-tumor antibiotics are our big DNA binding category. The taxanes and the vinca alkaloids the taxanes are non-DNA binding. The vinca alkaloids are DNA binding as well. That non-DNA binding category of the taxanes makes them sometimes fall on the list of irritant instead of vesicant. So that's why I say check your charts, check your policies, because it just depends on what source you're using. All right, our irritant drugs. Like I said, these can be a challenge to identify because some irritant drugs have been associated with extravasation injuries. And usually that's going to be like the cisplatin and the dacarbazine listed over there, vesicant-like activity in large volumes. So if you have a large volume, high concentration of cisplatin that extravasates, it can act more like a true vesicant, but is labeled as an irritant. And then the liposomal drugs, the protein bound, they can cause issue. And oxaliplatin, and here you'll see paclitaxel and Abraxane, the protein bound, and those can cause soft tissue injury. Again, can be listed on the vesicant or the irritant list in lots of places. All right, our initial management. Now that we've gone through all our drugs, what are we going to do when our patient is displaying evidence of extravasation? We're going to stop the infusion immediately. If it is a peripheral site, the extremity should be elevated, get that blood flowing back down towards the heart. Do not remove the catheter or needle. We need to assess the drug that is extravasated to determine if we need an antidote. So first, we're going to try to gently aspirate any fluid that's out, clamp it off, determine if we have an antidote that needs to be administered. If we do, is it one that we're going to use that catheter for? If we don't, then it will be safe to de-access or remove that peripheral IV for that patient. All right, here's our next poll everywhere. Cold compresses are always recommended to help reduce local discomfort. All right, we're looking good there. False is correct. So are we going to use hot or cold? Depends on the drug. Probably most of the time, it's going to be cold for our vesicant and irritant drugs. Most often, cold therapy is going to be advised for 15 to 20 minutes, up to 4 times a day for the first 48 hours. After that, there's not really any benefit to using ice packs anymore. Intermittent cooling is done to cause vasoconstriction in the area, so then the drug doesn't spread further and the local injury will just be isolated to where it extravasated instead of like traveling up the arm or in the chest. Some agents require warm compresses though, so you should look, because nobody's got this memorized, look to see what extravasated, and then you can determine if you need warm or cold. But we're talking etoposide, gemcitabine, oxaliplatin, and all the vinca alkaloids need warm compresses, which is thought to increase local vasodilation. So more blood flow to the area helps the body absorb the infiltrate and get rid of it from there. But that's 2 completely separate treatment responses, and the best thing that you can do is look up your policy. So we do have several pharmacologic treatments that should be done for different drugs, but we don't have any studies that compare all the existing drugs against each other, right? Usually these studies are done with one drug class and two antidotes or whatnot, but there isn't like a large study that evaluates all of them. So the data is a little bit, it's not as robust as we would like it to be. There have been studies where they have looked at glucocorticoids, antihistamines, sodium bicarbonate, heparin, lidocaine, and that has all proven to not be effective for extravasation injuries, either on the prevention side or the treating side. So I didn't include those in here because that will just be confusing. Just know that we have 4 antidotes that we're going to go over here. The first one is DMSO, dimethyl sulfoxide. So DMSO is an anti-inflammatory agent, and it is studied in anthracyclines, right? So it's applied either as a cream to the extravasation site or as a liquid, like dropper, to that area. And they do this 3 times a day for between 3 and 14 days. Really, you're looking for resolution of the redness and the edema and the pain before you discontinue the DMSO. Side effect is usually, right at the extravasation site, they're going to have some burning or tingling or redness. Oddly enough, patients do report garlic odor of their breath. And you should use this drug when you're using it with the cold compresses for the 2 days. So you apply the DMSO and the cool compresses happen 4 times a day as well. Our next drug is Dexrazoxane. I do have to say that one slowly. I apologize. Also for anthracyclines. So you may now know that we did DMSO for anthracyclines, and now we have this one as well. You would not use the 2 together. So you should check your policy to see if they recommend this versus the DMSO, or there are a few extra points that make this one a little bit more complicated. But it was first used as a cardioprotective agent for patients receiving anthracyclines. And then they, studied to determine that it helps with absorption of the iron binding at the site, the extravasation site, so then it can be flushed through the system. So they started giving it for extravasations, but you have to give it as an IV infusion for 3 days in daily doses, and it has to be given in the opposite arm of the extravasation. You give the first dose just as quickly as possible, no later than 6 hours after the extravasation, and then come back on day 2 and day 3 to have subsequent doses. So sometimes that can be challenging for patients to transport back up. This isn't an infusion that can be given at home, or, breast cancer patient that you only have one arm to use. That may make this not the best agent for them, and the DMSO is the better agent. Side effects include nausea, hematologic and hepatic toxicity. So these patients that have been given this medication can have neutropenia, thrombocytopenia, and elevations in their LFTs. Usually bilirubin is not affected. So here's our chart about the DMSO. It does have some dosing information on here, but the 4 drops, we also offer a cream applied twice the size of the affected area. And then the Dexrazoxane is 1,000 milligrams per meter square on day 1, and then 500 milligrams per meter square on days 2 and 3. And it's the opposite arm of the extravasation, and it's infused over 1 hour. And you can continue to use cold compresses with the Dexrazoxane, but not during the administration of the medication. Hyaluronidase is our 3rd agent here that is Used to treat extravasation, this one's going to be recommended for vinca alkaloids, etoposide, and taxanes. So this is one that's really important to keep that IV or either the cannula or the needle in place for the extravasation, because you can give this medication through that extravasated line. If you've removed the IV, then it needs to be given in 5 equivalent subcutaneous injections around the perimeter of the extravasation site. It really only has local irritating effects, either from getting it IV through an extravasated IV or from the subcutaneous injections. There are no systemic side effects from the hyaluronidase, and it's just one time. And then sodium thiosulfate is our last antidote we're going to discuss, and this is for high concentration cisplatin, bendamustine, mitomycin. It adds, it creates an alkaline-rich site, so it reduces some of the acidic properties of the infiltrate site, and then the extravasate, whatever drug is there, will bind to the sodium thiosulfate and can be excreted in the urine. This is another subcutaneous injection. This one is not IV, and they divide it into 4 sub-Q injections. And there haven't been any reported adverse events with the administration of the sodium thiosulfate. So here's a couple of charts for those guys. The hyaluronidase is going to be 1,500 units, 1 ml, so 0.2 ml per injection around the site. And then the sodium thiosulfate is 2 mLs divided into equivalent injections. So most data says half ml for 4 injections total. All right. Should we need a plastic surgery consult? That's going to be determined on the patient and some of their factors, right? Was it a vesicant right off the bat? Was it a large volume of extravasation? Do they have decreased sensation of the extremity? At any point, if they start to develop blister necrosis, they should go see plastic surgery. Our older patients and our younger patients should see plastic surgery probably right away. If there is severe pain, instead of reduction in pain or resolution of pain, they should see plastic surgery. And if there is minimal healing, they should go see plastic surgery. If there is any skin necrosis, chronic ulcer, or persistent pain, they should see plastic surgery, and treatments include excision of the extravasation area and possible skin grafting. So good old Ben Franklin here with his ounce of prevention worth a pound of cure. Our last poll everywhere question is, all chemotherapy extravasations are completely preventable?
And just a friendly reminder, with this being our last poll everywhere question, soon you will be able to start inputting your questions for Robyn. So get those ready and handy as we approach the second half of our talk, and we can talk with Robyn at the end.
I wish that this were true, that all extravasations are completely preventable, but they're not. Sometimes things are just going to happen. You have a great IV site and all of a sudden it's not. Someone you think has great veins just didn't turn out that way. So we cannot prevent all chemotherapy extravasations, unfortunately, but there is a lot we can do to make them as preventable as possible. Most of them can be prevented with systemic implementation of evidence-based, standardized administration techniques. So we have a really robust policy with great chart on antidotes and really nice outline of where to place peripheral IVs and assessing blood return on central lines here at UNC. And so I encourage everyone to check policy in their clinical practice locations and just be familiar with where that is and what that document includes. And if there are some gaps there, then I encourage you to communicate with your leadership on filling those holes. Staff should have familiarity, right? It's not a never event to extravasate, but it isn't something that you practice for, but should be aware of those first critical steps to take so that we can reduce serious injury. Pause your infusion, aspirate fluid, clamp the line, keep it in place until you determine what antidotes you need. Don't readily apply cold or ice until you know what the agent is and what the treatment is, because you can cause damage if you do. Medications to manage extravasations, those 4 antidotes we went over, should be readily available quickly from any pharmacy that you're working with. And then ongoing training and reminders and discussion with new staff to make sure that everybody is on board with where peripheral lines can be placed, how do you assess ports for patency, PICC lines, CVADs. We need to make sure that we have continual training for all staff. So some preventive measures with the IV site itself. Again, select those large veins in the forearm. Avoid inserting anything near tendons, joints, hands, shallow, bony prominences. Don't use places that bend frequently, the inner wrist, the AC, because when the catheter is bending, it's more likely to dislodge. Covered with a transparent dressing. I think we all try to make sure that we've done that, but really important to get those extra securing devices on there as things get pulled inadvertently. And, a Huber needle in a port can become slightly dislodged from a tug and then is like the perfect candidate to extravasate vessel through. If you have any doubt that your PIV is good at all, just change it. Patients are not going to love that, but you better safe than sorry in that case. And if there's any doubt that your central line is malfunctioning, you should get a chest x-ray. The venogram is a dye study where they go to radiology and push a dye through and take images to follow the line beginning to end to make sure there are no fractures or anything. That's kind of your next line if something looks okay on the chest x-ray but still isn't working very well. And then, tape down the extension tubing. And that's not just true for peripheral lines. That's going to be true for your central lines too. You want to make sure that things are not tugging that should not be tugging. Prevention associated with administration. So nursing needs to check for blood return before administering chemo. when the chemo is done. If you're using a vesicant, then you need to check for blood return even more frequently than that. If you're doing vesicants via peripheral lines, they shouldn't be, they should have a compatible solution running, and ideally gravity fed, not pump fed, so that you can continuously check for blood return and site patency. You should be looking for swelling or redness or tenderness at the IV site, which is why the clear dressing is important. And recognizing the signs, early signs of extravasation, where there maybe is just a little bit of edema, or the skin is cold, or maybe there's a little bit of pinkness to the skin, but it hasn't progressed to redness and there's no pain, should be early indicators that you need to check that line to make sure it's still functional. Random pain in the shoulder, neck, or ear on the side of your central line could be an extravasation. Fluid leaking into that space causing pressure. So always be aware if people are reporting unusual or new pain during an infusion, even if it's on a central line that needs to be assessed. And if you have any fluid leaking from around the dressing, you should check your site there too. All right, our providers on this call. So patients come to clinic and they see the provider, and plan is for chemotherapy. I know some, but not all, will discuss IV access with patients, but should be part of the standard conversation on do you have a difficult time getting IVs? Are you a hard stick? Do people tell you your veins roll? Even assessing their arms, if you're thinking you want to stick with a peripheral IV for their regimen, would be advised. A lot of this information comes better to patients from their provider versus the nursing staff. So educating the patient and family regarding how often we expect to put in an IV or draw blood during their treatment could kind of sway them one way or another towards the central line versus maintaining peripheral lines. If they don't have any issues with peripheral lines, certainly that is the best option, as it is the lowest risk for infection. And then some people are generally concerned about ports, getting a port placed. It's just not something that they're comfortable even thinking about. So engaging them on what questions or concerns they have about getting a port. And then there are treatments that they have to get a port without question, and that's all fine. But this group in particular, we want to talk to about concerns regarding, port's not 100%. Please let us know if you notice any pain or swelling during your infusion, after your infusion. All the education needs to happen with the patients in every touch point at the healthcare system. And I really like this chart. So I'm going to kind of walk you through this, right? This was on an 8.5 by 11. So excuse me that it goes down and over, right? So patient complains of pain, right? Swelling, redness, tenderness, whatever. So the nurse comes to assess the IV and they suspect extravasation. So step 1, stop your infusion. Do not remove the needle. I would say elevate the extremity if that's possible. Attempt to aspirate any residual drug. Notify your provider, right? So then we have our antidotes down here. So our alkylating agents get the sodium thiosulfate, possibly DMSO, or plant alkaloids. They get the hyaluronidase with the warm compresses. That's going to be the DNA that's going to be your anthracyclines. Those are going to be cold compresses, DMSO, topical again. At this point, the patient goes on 2 different pathways over the next 1 to 2 weeks, right? Is this a large extravasation? Did we start to develop ulcers? Do we need to go ahead and involve surgery before this becomes a problem? Yes or no. So we can observe no ulceration and healing. Patient comes back, follow up in clinic, return and start their treatment. Maybe we do have significant ulcer development. Then surgery needs to be involved. We excise. Maybe we do a graft. That's going to involve some physical therapy for healing, in addition to, pain and risk for infection. And then when they're better, healed, we hope, they follow back up and we can resume treatment. On the opposite side of that, you've got your small extravasation injuries, where you can just observe those patients. If you have no ulceration going forward and they've been managed with the appropriate antidote, they continue with no ulceration and healing, and they follow back up and they resume their treatment. So there's a couple of different ways that people are going to go through the healthcare system after an extravasation. And I just thought this was a really nice chart to kind of like show that flow. We wish it was perfect every time, but it's not. And oftentimes patients will have extravasations and don't have follow-up appointments for 3 weeks until their next chemo. Really, we should be trying to get pictures or have physical assessment of that extravasation area on vesicant drugs once weekly, so that we can continue to monitor that area for ongoing healing. And if we're not seeing that healing, sending them over to plastic surgery. I am really passionate about this topic, considering I've spent the last 3 years in infusion, working closely with the nurses, and think that this is an often overlooked area of care, because you just think you put in an IV and you give chemotherapy and we call it a day. And that people forget that that doesn't just go smoothly all the time. And just hope that everybody maybe got a little nugget out of this, so that we can all be a little more educated about how to take care of patients should this occur in their treatment.
Thank you, Robyn. Yes, I agree. I think there's more than one nugget to take from your talk. And I think two things to highlight is, one, the role of everybody who has a touch point with the patient, discussing this and talking about IV access and where you put IVs, that it doesn't fall to one person, right? Because it's such an important topic that, right, may not happen all the time. And also highlighting the role of infusion advanced practice providers. I think you guys are sometimes the first line to address these, and having an advanced provider to respond to these that happen in infusion. Granted, I know sometimes complaints don't happen until the patient leaves, but I know what an asset you have been, and being an infusion APP, I think is really valuable. So a very valuable role, especially for this topic. So thank you for spending your time this afternoon, Robyn. Thank you for sharing all of that. And we will move on to questions. So please, if you have a question or clarification for Robyn, put that into Poll Everywhere and we will get to it. So our first question, Robyn, where's the best resource to know whether to use heat or cold? So coming from different areas that may not use these frequently, and only if we have them off service for a cardiac reason. So
yeah. So thank you, Tammy. I think that this is an excellent question, right? Oftentimes, and I am guilty of that as well, I think that this information is going to just the infusion staff or the floor nurses or whatnot, but these patients can be anywhere. And this was just a chat about chemotherapy extravasations. There are many other medications that can cause severe extravasations. So resources. I think your package insert usually has the data on it on if your product extravasates, what the treatment would be. So you can find that on any medication. It doesn't matter if it's a vesicant or a non-vesicant. It'll say, if it infiltrates, then, use a cold pack or a warm pack or whatever. That's usually in the package insert. If you're at UNC, I would use the extravasation management policy. Let me see, can I make this go backwards? No, wait, yes. Extravasation, infiltration of caustic agents, prevention and treatment policy. That has a lot of really good information in it, and it lists more than just chemo. So some of those pressors and antibiotics and things like that, and how to treat if there's an antidote versus just warm compresses or cold compresses. But I would start with the package insert.
Great, thank you. Any other questions?
My bad.
Let's go back one just in case.
Yeah, and I just wanted to say, like you said, Tammy, every person that is interacting with a patient here in the system is important to have these conversations with them, right? There's no one person that is more important for this information to come from versus another. I think that, patients get information from a lot of different resources, but the nurse in the lab can talk about lines. The doctor or APP in clinic can talk about extravasation if it's a peripheral IV versus if they have a port. The bedside or chairside nurse can all have these conversations, and that information coming from all of those people is really important.
Agree. So thank you all for spending this past hour with us. And thank you to the University Cancer Research Fund and to the Lineberger Comprehensive Cancer Center. And a huge thank you to our Lineberger Cancer Network, our telehealth team who make all this magic happen. So thank you, Tim, Benny, John, Oliver, Andrew, Nadja, and Patrick.